start this out. So I just wanted to welcome everybody to our very first virtual Cancer in Focus Forum. Typically, we would be in person on this day at this time in a lovely room at the Sun Valley Resort presenting this information, but we're really excited that our doctors were able to set aside some time for us with their busy schedules with clinic and research to be able to share with us kind of what is the latest and greatest in what's going on right now in cancer research and therapies, which we feel really ties into the mission here with our organization. So I'm Hannah Stotts. I'm the Executive Director of the Killebrew-Thompson Memorial. And just to give you a quick overview of our plan today, we are going to be hearing from some leading doctors in the field of oncology, and they are going to hopefully get us excited with the advancements that are currently happening in cancer research and care. And we'll have a Q&A at the end of their presentation, so there will be an opportunity for you to pose questions directly to the doctors. If you've not been a part of a Zoom webinar before, the feature that we'll be using is the chat function that's at the bottom right of your screen. You can just enter a question that you have in the chat box, and I'll be fielding those questions and serving them up to Tucker and the doctors. But just know that that'll be the way to communicate with us. We won't be able to hear you or interact directly with you. So I'd like to tell you a little bit about the Killebrew-Thompson Memorial. We are a cancer research fundraiser that's held in Sun Valley every year. We have been around now for 44 years. This is our first ever virtual year. We're normally here in person with about 300 people participating in the various events that we host. We host a 2-day golf tournament, a live auction gala, a benefit concert, and of course this educational forum, which is usually free and open to the public. So it's exciting now to be able to broadcast this online and have more people have access to the information that doctors will be sharing with us today. So our organization over that 44-year history is really proud to have raised over $18 million that's gone directly to cancer research at our 2 beneficiaries. Those being St. Luke's Cancer Institute in Boise, Idaho, formerly known as the Mountain States Tumor Institute, or MISTI, and the Masonic Cancer Center at the University of Minnesota in Minneapolis. So those are our 2 beneficiaries that are doing some just leading, cutting-edge work in cancer research and patient care. And we're fortunate enough to have 2 doctors from those organizations ready to present some information to us today. But I am lucky to be able to throw the rest of this show to Dr. Tucker LeBien. He is the infamous doctor from the University of Minnesota in our tournament because he has a killer golf game, but he also boasts over 40 years working in cancer research at the University of Minnesota. And we're very proud and honored to have had him involved in our event for so many years. And I would like to transfer it to you now, Tucker, and you can introduce the doctors. Tucker will be serving as our moderator today for the discussion.
Okay, well, Hannah, thank you very much. I think before we start, we need to, on our own little Zoom environments here, have a shout out to Hannah Stotts and Ashley Wells for their remarkable efforts to actually put this in place, not only this event this afternoon, but the entire virtual golf tournament and the event that will occur tomorrow. So I'm clapping here feverishly and passionately, hoping that Zuckerman and Weigel will be too, as a minimum amount of
and a pleasure.
So way to go, you guys. So I'm professor of laboratory medicine and pathology at the University of Minnesota Medical School and former deputy director of our cancer center. I've had the, as Hannah was suggesting, I've had the privilege of representing the university at the tournament for, I believe, about 22 years. And it has been one of the highlights of my professional career, and I'm thrilled to be part of this unusual circumstance this year. So I want to thank all of you who are online with us, whether you're a virtual player or a supporter of the KTM, or a resident of Sun Valley or a resident elsewhere. We're delighted you could join us. I think before Drs. Weigel and Zuckerman speak, it's appropriate to recognize the reality that we're all living in a COVID world, and this has impacted everything. I think you'll hear from Brenda and Dan to some degree how it has impacted cancer care. But life goes on, and life has been going on, and cancer research in our individual shops is proceeding as ambitiously as it always has. And for that, we just want to reemphasize how committed we are to develop, I should say, better tools for diagnosing, classifying, and treating this disease. So it's onward and upward. So what we're going to do, as Hannah mentioned, is we're going to have two presentations. They're about 15 minutes apiece, I believe. And at the end of those two presentations, we will open it up for questions. I would be thrilled if you flooded the chat room with questions of any kind relevant to these talks or anything that you're thinking about. We want to do what the best we can to answer those. So by order of the coin toss earlier today at the 50-yard line between Idaho and Minnesota, it was decided that Brenda Weigel will speak first. Brenda is professor of pediatrics and the head of the Division of Pediatric Hematology Oncology at the University of Minnesota Medical School. Brenda, we're delighted you're here.
So Tucker, thank you. And I want to just echo my thanks to Hannah and Ashley as well for the incredible job that they have done to pull this off in this virtual world. I'm just going to share my screen here and get everything ready to share with you the update from the University of Minnesota Masonic Cancer Center. There we go. I hope everyone can see that. I get some nods of heads. So it is my pleasure. And actually, I will also echo what Tucker said is I have had the pleasure of being now out in Sun Valley for the last few years with Tucker representing the Masonic Cancer Center in the University of Minnesota. And as those of you may know, the real golfer in my family is my son. And he was crestfallen this year to not be part of the tournament and the festivities. So we are all in moving forward and hope we can be together next year. So I am delighted to give you an update of sort of how KTM has been instrumental in supporting cancer research at the University of Minnesota and what your support has meant, especially in these changing times. Oh, hang on. There we go. All right. Just to give you a perspective, and I think it is very helpful sometimes to look kind of where we've come and where we've been. Cancer mortality in the United States peaked sort of just here in the 1990s. And we have actually seen cancer deaths from in the United States decreasing over the last couple decades. And you can say, well, what if we have the actual predicted rates? You can see here this blue line and then the red line. These are the predicted number of deaths had changes not occurred sort of in the mid-90s to change the tide. And this does not mean that the actual numbers of people with cancer are going down. It actually means our ability to treat, recognize, and deal with the cancers is improving. So we are really seeing sort of what's called a flattening of this death curve in the United States. And you may ask, what has led to the flattening of that curve? And I can tell you, KTM, over its 40+ years, has really contributed to the flattening of that curve through the research and initiatives that you have supported. And really key to that is the understanding of what causes cancers. So the kind of what's called etiology, or what's the causes. But very importantly, that leads to the development of therapies. And what we have gotten over time is better and better, because we understand more about the cancer cell, we understand more about how we can target the cancer cell. We have been able to develop clinical trials, and I'll speak a little bit to this, that are pivotal to bringing those new therapies to the clinic, so from that bench to the bedside, as we identify new treatment targets. And this has really been the hallmark of the contributions that KTM have played to the flattening of this curve. And where this all started and where the biggest impact has been at the University of Minnesota has been KTM's ongoing support and pivotal support of our cellular and immunotherapy program. So we now go back over 50 years to the very first bone marrow transplant It was done by Dr. Robert Good, here pictured, and Dr. John Kersey, the first director of our Masonic Cancer Center, did the first bone marrow transplants in the 1960s. And this is actually the first patient that was transplanted with lymphoma who is still alive today and doing very well. So we serendipitously are building on a tremendous legacy and the shoulders of giants in the field. And we have really utilized, and I will share with you, really a pivotal backbone is the understanding of the immune system and how we develop targeted cellular therapies and targeted drug therapies to really enhance the immune system, so the T cells and the natural killer cells of the immune system, to fight cancer and to be used as therapies. And this has really been on the shoulders of really understanding how we could use bone marrow transplant or cells from the entire bone marrow and start to isolate out individual cells to use in treatments. And so currently, the support that we received in the last year from the KTM event of last year has built on that long legacy, and funds were directly supporting natural killer cell, or NK, you'll see this a lot in my next few slides, cell therapies to treat particularly cancers, including both solid tumors and lymphomas. And this work is being led by Dr. Jeff Miller. And we've also utilized and realized that we need to, after a cellular transplant or other immunotherapies, really study how we can help the immune system recover and get back to normal, to continue to fight infections, but also to stave off the recurrence of cancer. And that is additional work that's being supported. Support also went to very specific faculty working in specific areas on projects that range in the leukemias, which we know that Danny Thompson, it was really the hallmark of generating a lot of commitment and interest to using KTM support for leukemias, as well as the cellular therapies in our program. The other big area that KTM supported this last year, which is critical to bringing new therapies to patients with cancer, is the ability to conduct clinical trials and the support for clinical trials within the Cancer Center. So in the calendar year 2019, we actually enrolled almost 3,000 individuals onto what are called interventional trials. And those are trials for treatment or services or other questions that are directly related to the care of individuals with cancer. We currently have 232 trials open, and opened 86 of that. 86 of those were new during the last year. And this type of support is pivotal for us to be able to bring the therapies that we're developing in the lab and therapies developed by others to our patients and families. So one of the big unique aspects of the University of Minnesota is a center that Dr. Tucker LeBien leads, which is the Minnesota Molecular and Cellular Therapeutics Institute. So the MCT facility is really pivotal to us being able to utilize the resources at the University of Minnesota to develop and generate the cells and the cell therapies to use in these clinical trials. Leading this effort is the current deputy director of the Cancer Center, Dr. Jeff Miller. And in this last year, as Tucker said, we have continued to forge ahead with developing these novel cellular therapies for cancer, but we recognized that in this time of COVID, that some of our strengths in cellular therapies, our understanding of the immune system and our ability to deliver these cellular therapies from a world-leading institute, was potentially something that could be used to combat COVID. So not at the diminishment of pulling our work forward for cancer therapies, but in the addition of utilizing this knowledge and skill set to actually start to tackle the treatment of COVID. So we were uniquely positioned because of our expertise in cellular therapies to not only continue the cancer fighting cellular therapies, but leverage the facilities at the University of Minnesota for COVID. So what is a natural killer cell? So a natural killer cell is a scavenger. It's a scavenger of the immune system. It basically goes around in our normal natural immune system and finds infected cells particularly with viruses typically, and targets a marker on their surface, an antibody or another signal, and says, this is something I should seek and destroy. It's a killer. That is exactly what it's supposed to do. Dr. Miller has successfully utilized these cells and engineered them or used them to target cancer cells in the same way that we would utilize in the body. They would be utilized to fight infection. And so what Dr. Miller and others realized was actually in patients who had COVID-19 from other parts of the world, particularly from China, they actually had very diminished and ineffective natural killer cells. And so he realized that we have cells at the University of Minnesota that we have engineered and generated to treat cancer, these natural killer cells, that if you were able to infuse them into a person with COVID, could they be released as sort of an army marching towards these COVID infected cells as the way he was using them to march towards cancer cells utilizing a different target? So one of the really pivotal things over the last couple of years at the University of Minnesota has been our ability to develop not only what we call these genetically engineered NK cells, or really kind of designing them for a particular patient with a particular cancer and sort of a targeted therapy, to developing what we're calling off the shelf and natural killer cells, where you can actually take a cell and turn it into a natural killer cell that you can use for therapy in multiple people. And so this was really what we leveraged, not only for targeting tumor cells, but also for targeting COVID. So in this system, and I'll walk through this with highlights, we are able to take cells that are what are called pluripotent stem cells or induced pluripotent stem cells that can actually be engineered and grown up to develop into specific natural killer cells that can be used for therapy. And this is something that is done in the MCT facility that Dr. LeBien runs, and we are able to generate cells that then form the ability to become natural killer cells with very specific targets that can be stored and essentially utilized in an unlimited fashion for multiple doses for a particular patient, and we actually are able then to deploy them in a much more uniform, consistent, and on-demand manner. This has been a real tour de force over the last couple of years to be able to do this, and it was really developed for the treatment of cancer, so that we could say we have a trial and these are 3 examples of cancer trials where this exact technology is being used to take these natural killer cells that we have grown up for specific targets and utilizing them to treat leukemias and other solid tumors such as ovarian cancer. But what Dr. Miller realized was that we could do the same thing to treat COVID-19, because COVID-19, as I mentioned before, there is information to say that the natural killer cells are depleted or deficient in patients with COVID-19. And COVID-19 generates a tremendous what's called inflammatory response. And one of the things that causes people to get so sick with COVID is because there's so much immune response turned on to the virus and the virus infected cells. And one of the things that the natural killer cells can do is they can attack those infected cells and start to dampen down the immune response and hopefully allow the body to actually have less damage from a very turned on immune system. The other cells that we are able to generate are what are called regulatory T cells. And these regulatory T cells, as the name suggests, regulate the immune system. And one of the things is that we can actually also isolate these cells to try to turn off the immune system, to dampen down that inflammatory response. And Dr. Wagner, also, who is leading the Cellular and Gene Therapy Institute, can take cells that normally form sort of the kind of, I would say, the more supporting structure of the immune system, these what are called mesenchymal cells. They also help to dampen down the immune response, but also importantly, heal the tissue that was caused by the inflammation. So there was the development of this stepwise cellular therapy response using natural killer cells as an antiviral therapy, and also somewhat decreasing the immune inflammatory response, giving regulatory T cells to dampen that immune response, and then the mesenchymal cells to help heal. So as of early this summer, the FDA did approve the very first natural killer cell COVID-19 trial using the cells that Dr. Miller had and is continuing to use in cancer therapy, but pivoting to say we are going to use these to try to treat COVID-19. The very first patient was treated the first week in August with these cells, and so we are working towards learning more as we initiate these very first trials with these novel cells. We have had several other partnerships and clinical trials looking at that interface between our cancer care and especially how COVID-19 is affecting patients with cancer, as Dr. Kratzky is looking at with a natural history study. COVID-19 has also affected our patient care. We had to pause all elective procedures for 3 months. We did have to pause clinical trial accrual for a few months, but I am very happy that as of about a month ago, we have reopened our clinical trials to 50% capacity. And our clinic visits, we have remained open through the COVID times, mainly doing a lot of phone and virtual visits, but ensuring all patients with cancer are receiving the appropriate care that they need and required during this time. So KTM has an incredible lasting, but not just building on where we've been, but moving into the future. We have launched careers in cancer research, and KTM support continues for faculty doing very important work in our key priority areas of cellular therapy and leukemia. KTM support has driven the discovery, and that sustained support over many years has allowed us to build cellular therapies and immunotherapies leading towards new therapies for cancer, and now being utilized, hopefully, for treatment of COVID-19. This continued support is critical for this innovative cancer therapy development. And KTM's continued support allows us to be able to provide clinical trials, to provide that critical ability to deliver and translate the science from the lab to the clinic, to be able to have patients benefit from these novel therapies. And most importantly, it is absolutely recognized that we need community partnerships, and they are critical to us maintaining our outstanding, which is the highest ranking possible from the National Cancer Institute for the University of Minnesota Masonic Cancer Center. So I can't thank you enough for your ongoing support, for your support that is allowing us to really move the bar and build on that lasting legacy, but moving towards the future for these novel therapies. So with that, I will turn it back to Dr. LeBien to introduce Dr. Zuckerman.
Brenda, thank you so much. If you pull that off your screen now. So those of you out there who have questions, and I hope you are thinking about questions that you'd like to ask, please don't hesitate to submit those through the chat mechanism. And we're looking forward to providing answers. So Our partner in this endeavor, our wonderful partner, Dan Zuckerman, who is a medical oncologist and the medical director of the St. Luke's Cancer Institute, I think maybe recently, a recent name change, at least from last year, is going to give the next presentation. And Dan, welcome. Thank you for your time and efforts. And we're very interested and look forward to what you have to tell us.
Thanks so much, Tucker. Can people hear me?
Yeah.
Okay, great. Yeah, and are you can people see my screen? Sorry, I just want to confirm.
Yeah, everything looks down
Okay, great.
Everything looks
Perfect.
good, and we hear you.
Okay, great. So no, thanks, and Brenda, great job. Tucker, thanks for the introduction. And again, I'm Dan Zuckerman. I'm the System Medical Director for the St. Luke's Cancer Institute, which is Tucker and Hannah just mentioned. We're formerly known as MISTI, the Mountain States Tumor Institute, and this year, as part of our 50th anniversary, we have changed our name to the St. Luke's Cancer Institute for the simple reason to include the word cancer. Tumor had been somewhat antiquated, and to just reflect the fact that we are the cancer center, the Cancer Institute of St. Luke's. So I'm going to give again a shout out to Hannah and Ashley for pulling this off, and to be able to use this technology and walk you through some of the things that we're doing for cancer research at St. Luke's Cancer Institute. I'd want to, let's see if I can get this into actual, there we go. So I just want to first of all acknowledge that, actually some of you may know or may or not realize I was actually a history major in college. So I want to just at least acknowledge and honor the history of Harmon Killebrew, and Danny Thompson. And so just a reminder that Danny was a journeyman infielder for the Minnesota Twins, and he was diagnosed with leukemia at a very young age and ultimately succumbed to leukemia. And his teammate Harmon was from Idaho and wanted to honor Danny in some way, and that's why there's this history between Minnesota and Idaho in terms of Harmon wanting to host this tournament out in the beautiful Sun Valley, but that originally the funds had gone University of Minnesota solely, and then after a few years have been split between us and the Masonic Cancer Center at the University of Minnesota. But that's the origins of this tournament. I'd show you just a little bit of just who we are. We take care of cancer patients and do cancer research in most of Idaho, Eastern Oregon, Northern Nevada, and actually have 5 sites spread through South Central and Southern Idaho, centered in Boise. Would highlight that we have a new facility coming out in Nampa, which is about 20 miles to the west and one of the fastest growing parts of the country. And they're in rendering, but actually that building is going up, and we're going to be able to have a state-of-the-art $30 million cancer center for our patients who live in Canyon County to the west of us, which is an incredibly rapidly growing part of Idaho. So I'm going to talk about immunotherapy, which you heard a little bit from Brenda about, specifically with cellular therapy and NK cell therapy, and targeted therapy, circulating tumor DNA, and give you a couple examples of the clinical trials and experimental therapies that we're doing here and offering to patients in our area. And then end with just a reminder of how philanthropy and the generosity of our friends at KTM are actually leveraged to help us get federal dollars through the NCI. So as a child of the 70s, everything comes down to Star Wars for me. And so when I explain what immunotherapy is to patients, it really comes down to telling patients that it's really the scene from Star Wars where Obi-Wan Kenobi tells the stormtroopers, these aren't the droids you're looking for. And that is, and fundamentally, a way to explain the mechanism by which some of these newer drugs, again, here we're talking about antibody drugs. So I'm going to talk to you about checkpoint inhibitors, which are commercially available, but have come up through clinical research that's been done at places like St. Luke's and Masonic and all over the world. But what I'm showing in this slide is really the fact that tumor cells, cancer cells, shown in brown here, one of the ways that they're able to evade detection and frankly escape and invade and spread is that they can tell our T cells to ignore them and to basically turn off. And so one of the most recent developments in immunotherapy has been use of checkpoint inhibitors, which are not cells themselves, but a protein, a monoclonal antibody, and depicted by this green molecule here that actually shuts off the ability of the tumor cell to tell our T cells to ignore them. And in effect, what the tumor cells are doing are trying to do a Jedi mind trick on our T cells and to say, hey, these are not the cancer cells we're looking for. And that's how I explain the mechanism by which many of these new immunotherapies work, is by telling the T cells that these tumor cells are indeed the droids or the tumor cells that we are looking for. I'll show you just an example of some recent data conducted nationally on a drug called atezolizumab and used with chemotherapy in triple-negative breast cancer. So these new immunotherapies have been proven to work in now close to 10 different cancers, but breast cancer has been a difficult inroad. And so just recently, for the first time in a very dangerous and aggressive form of breast cancer called triple-negative breast cancer, which comprises about 10% of breast cancer, we saw really the first hints that immunotherapy could work in this subset of breast cancer in the advanced setting. So currently here at St. Luke's Cancer Institute and other areas in the country, we have a clinical trial that's using a similar checkpoint inhibitor, in this case called pembrolizumab, and moving it, the term we use is upfront, and looking at it in earlier stage disease, so that very frequently women with triple-negative breast cancer, we will initiate treatment. They'll actually get chemotherapy as standard of care before surgery. And then after surgery, we're able to see how much residual invasive cancer is left in the breast or in the adjacent lymph nodes. This trial is a randomized trial and does randomized observation, which is the current standard of care that typically after chemotherapy and surgery, we're aware that if there is residual disease in the breast, that's a more ominous sign prognostically, but that currently there's been no proof that the addition of other therapy has really been beneficial. And so this is going to move a type of checkpoint inhibitor called pembrolizumab into an upfront setting and test further whether a checkpoint inhibitor, meaning immunotherapy, can work in breast cancer. And so one of the most important trials going on in the country is something we have here at St. Luke's and that we're able to offer to patients all over our state and region. I'll shift gears and talk about targeted therapy. So really when you really look at what's gone on in oncology in the last 10 or 15 years, is speaking big picture that there really are the paradigms of immunotherapy, as explained by Brenda before me, and me talking a little about checkpoint inhibitors, but also the concept of targeted therapy, meaning that there are specific gene or genomic mutations that occur in cancer. It's frankly what makes cancer cancer. And it's by developing drugs that are more specific than chemotherapy, so targeted therapy, that we believe, and we've demonstrated ever since really 2001 for the first time in a type of leukemia called chronic myeloid leukemia, that we can target certain gene mutations. So a very important study that we have going on in lung cancer, actually, older versions of clinical trials would often just take all patients with lung cancer, or breast cancer, or colon cancer, and enroll patients simply based on the type of cancer they have lung, and either give a therapy or randomize to standard of care and give an experimental therapy. And what this slide is trying to show here is that nowadays we have trials where we're actually testing tumor DNA for specific mutations, where here PI3 kinase is a specific gene, CCND1 is another gene, FGFR, these are all different gene mutations where we're actually, based on the specific mutation, using different targeted drugs, some of which are commercially available in other settings, and some of which are still within the pharma pipeline and don't even have names, such as here, AZD4547 is a drug from AstraZeneca that is an experimental therapy against FGFR. And so these are the natures and the complexity of the clinical trials that we're conducting. These require more biopsies, they require more blood samples just because of that genomic complexity. And so a lot of the funding that goes, comes from KTM and from the NCI for us, goes towards supporting these studies and frankly paying for the logistics of these studies. As I alluded to, I can't, resist talking about, even though targeted therapy has been very promising, we have a lot of trials that look at using targeted therapies in different cancers. There is still some question about whether this will ultimately work. I have to here put in just a little bit of plug, is that I run a cancer institute, I'm a clinician, I'm a physician scientist, but I don't do basic science in the same way that Brenda and Tucker do, since we don't have a medical school here. But I was asked by by our larger society, ASCO, to write an editorial about the state of targeted therapy in cancer care in America. So my only claim to fame in publication is the fact that I was able to sneak a Star Wars quote in to the beginning of my editorial, and that got and the ASCO board was okay with that. But this is Luke right before they're about to attack the Death Star, telling people, I used to bullseye womp rats in my T-16 back home. And that's and that metaphor of us using targeted therapy and what Luke Skywalker did in the trenches of the Death Star, again, it's for him to be successful, that was predicated on the fact that where he was targeting, that thermal exhaust port, actually would be Achilles heel of the Death Star. And that's what, by and large, we're still really figuring out with cancer, is that some of these targets that we hit may not be enough to take out the cancer, and we need to refine those. Many cancers have multiple targets that we look for, and some cancers have false targets, or we have drugs that don't hit the targets. And so this is still relatively early in 15, 20 years of oncology. That's a fairly short time for us still doing research to sort this out. So I'll use a specific example here of a drug called cabozantinib that we see here. This is a targeted therapy. It's a small molecule tyrosine kinase inhibitor that we know actually hits several targets that are involved in cancer therapy. So c-Met, AXL, VEGFR. The HIF pathway actually was just the most recent co-recipient of the Nobel Prize. Bill Kalin was someone that I was fortunate enough to train under at Dana-Farber. And so he spent his entire career in the lab, and it continues to do so, and helped define the HIF-1 pathway and how hypoxia can lead to tumorigenesis. And again, recently received the Nobel Prize for that. That was decades ago that he did that work, and only recently do we now have drugs that can actually target that. So one of the things that again, may not seem like rocket science, but that really is very important, is a fairly recent illustration that can we use targeted therapy and immunotherapy together? And again, these paradigms have proceeded primarily in parallel pathways that have not really crossed. And so what I'm going to show you here is a basic science data showing the use of a type of targeted therapy here, lenvatinib, a checkpoint inhibitor like the drugs atezolizumab or pembrolizumab that I showed you earlier, in cell culture, looking at tumor growth on the y-axis and time in the x-axis, and simply showing that, frankly, a vehicle, again, is basically your placebo, that these tumor cells just keep growing unabated. When you use a targeted therapy, we suppress growth to some degree. When we use immunotherapy, we just suppress growth to some degree. But then in combination, at least in the lab, there seems to be a synergistic effects. So a follow-up to this is actually a study that had been published just last year, looking at, again, this targeted therapy, lenvatinib and pembrolizumab, in women with advanced endometrial cancer. It was a phase 2 trial. All patients got it. I'll show you what's called a waterfall plot here, where basically anything below this line, the x-axis, shows tumor shrinkage, and anything above it shows tumor growth. And we can see for the 30-plus women that enrolled in this study, almost all the cancers had some degree of shrinkage. So here, this is about 20, 30, 40% shrinkage. And that some, even 3 or 4 patients here, had 90 to 100% shrinkage in their tumors when combining these two approaches. So one of the most important trials we have here, newly opened, that's available for patients with kidney cancer, gives patients with kidney cancer the current standard of care, which is combination immunotherapy by itself, but then looks at an experimental arm where instead of continuing immunotherapy alone, that's the nivolumab every 4 weeks, that we're actually combining nivolumab, a checkpoint inhibitor that I had referenced earlier, with cabozantinib, a targeted therapy. And so that's something that we're very excited about, and to be able to offer to patients. I'm going to actually move forward, since this is some data I presented before, and actually want to talk a little bit about actually trying to get up front and actually learn more about cancer before it spreads, and figuring out who needs therapy and who doesn't. So I'm going to talk just a little bit about colorectal cancer and the use of circulating tumor cells, or here actually what is actually cell-free or circulating tumor DNA. So we know that tumor cells, as they break apart, will release DNA fragments into the serum, as shown here. And that actually, this case using colon cancer, one of the conundrums of current standard of care in colon cancer is that we know after colon cancer that it's removed, patients who have stage 2 or 3 colon cancers, unfortunately, some of those patients are destined to relapse, to have a recurrence of their cancer, as shown here in red. And currently for stage 2 patients, it's quite a bit of a debate about whether these patients should be observed or whether they should be given additional chemotherapy. So for one of the first times we actually have a trial here in colorectal cancer, stage 2 colon cancer specifically, where we actually can take circulating tumor DNA and randomize patients to what is currently the standard of care. Is that even though these patients have some degree of relapse, their standard of care by and large is to observe them. But actually, the experimental arm here, we will be using circulating tumor DNA to decide on whether or not patients actually get assigned to chemotherapy based on whether circulating tumor DNA is detected or not. So I'm gonna come to close to the close of my talk, and again, just want to say that research doesn't happen in a vacuum. So even here in Idaho, where we're the largest cancer institute between Salt Lake and Seattle, and we're able to offer our patients amazing things, and in great part through the generosity of KTM. We still do this in collaboration with other centers. We are able to, through an NCORE, which I've talked about before, which is the National Community Oncology Research Program, are part of a consortium with Swedish in Seattle and Providence in Portland. We're able to leverage and harness resources and have economy and scale in terms of conducting, opening, regulating, and doing trials through the entire Pacific Northwest. So I'll just again summarize some of the studies that we have going on at St. Louis Cancer Institute that are dependent upon the support of KTM. And again, the breast cancer study I mentioned using immunotherapy. There's actually a second one here, which I didn't go into detail about. Our circulating tumor DNA study. Have an ongoing study in conjunction with Dana-Farber looking at high-dose vitamin D and colon cancer. And then again, this is the combination therapy trial looking at targeted therapy plus immunotherapy in patients with metastatic kidney cancer. So I appreciate everyone listening. Again, want to give my thanks to the entire KTM board and to all of our generous donors, and again to Hannah and Ashley for putting this on. So I will stop there.
Okay, Dan, thank you. That was just terrific. So, Dan and Brenda, I see your voice active here. We have a couple of questions that have popped up here that I would like to start with, if I may. So I'm going to toss this one to Brenda first, and then we're going to hear Dan's perspective. So there's a question here. I'm not going to say who it's from because, well, I don't know if that's appropriate or not. I'm not sure. It's from a very bright person. Hannah, should I say?
Yes, that's
okay. It's Jeff Sillick. So,
it's our friend at St. Louis.
The famous Jeff Sillick.
I'm ready.
The question is, this is a very interesting one. Mm-hmm. He says very rare cancers have fewer patients, which logically make clinical trials more difficult to conduct. Mm-hmm. There's also probably less bench research addressing very rare cancers. Therefore, how does medical science address these very rare cancers? So let's hear from Brenda first, who studies some rare cancers, and then we want to hear from Dan because he does as well.
Yeah, so thank you for the question. It actually is probably one of the questions of the era. As we learn more and more about cancer biology and maybe some of the kind of triggers of cancer or some of the targets of cancer cells, we're finding out sort of that what we thought was one type of cancer is actually many, many subtypes of cancers, and even common cancers like lung cancer, there are incredibly rare subsets. And doing pediatric cancer, pretty much every cancer in pediatrics is a rare cancer. So I can tell you, as we start to do this more and more and we split into smaller and smaller groups, it is actually something, to be honest, I face almost on a daily basis, is how do you do some of these studies and how do you do the models and how do you work on this? There's a couple strategies. One is, I think there are some terrific federal initiatives to fund research in rare cancers. I would say there's been somewhat of a pivot to actually recognizing that there are, and not to the detriment of some of our big cancers, but also to say, how do we really designate funds towards that? So that is one thing I think that's been helpful. Having said that, I think the other thing is we're really utilizing novel trial designs and starting to really say, can we use clinical trials in a different way? Can we use fewer and fewer patients? And what we're seeing is with some of these drugs, So, you know, as Dan mentioned, cabozantinib. Well, cabozantinib is a targeted therapy, but if you have a particular disease where they have the targets of cabozantinib, you need fewer patients to actually show benefit because they have a greater chance of response. So you actually have to kind of have less patients actually enroll for how you design the trial. And also trials that involve not we're moving away from trials that are like a breast cancer trial or a colon cancer trial, but are trials that say you have this particular marker, so you are eligible for this therapy. So I think the world moving forward, we're going to get to this where you're not saying I'm just treating a breast cancer or a colon cancer or a leukemia. I'm treating this marker on this cell, and oh, by the way, you happen to have a leukemia, and you're going to treat it with that. So I think there are ways that we're really working to design trials very, very differently than we ever have.
Thank you, Brenda. Dan, your thoughts?
Yeah, no, I would follow up on what Brenda's just said, is that trial design is a bit different now. And so what Brenda just mentioned, we often gets referred to as a basket trial. And so, for example, you know, we and other sites around the country have had a specific study for rare tumors, and called the DART study. It stands for the dual anti-CTLA-4 and anti-PD-1 blockade in rare tumors, thus DART. And it actually baskets 52 different incredibly rare tumors, things like salivary gland tumor or trophoblastic tumor, many sarcomas, some neuroendocrine tumors, that any given location, whether that's here in Boise or in Minneapolis or anywhere, even in some of the world's largest centers, we may only get 1 or 2 or 3 patients a year. And so what that basket trial does is it gives a place for an institution like ours and others to say, for all these 52 different rare cancers, we actually have a clinical trial for you in which we're using dual antibodies, immunotherapy antibodies, and trying to get a signal by aggregating all these rare tumors literally into a single trial, and then working the statistics from there, because this trial can be open at St. Luke's Cancer Institute here in Idaho. It can be open, it's open in Masonic in Minneapolis, or at Dana-Farber in Boston, or MD Anderson, or even in remote places in South Dakota. And so that basket design allows us to aggregate rare tumors into a single trial, and then break down the statistics by specific disease from there.
Yeah, that's Dan, I'm really pleased that you raised the concept and now reality of these basket trials, because prior to our genetic understanding of all types of cancers, I'm sure that you and Brenda, as practicing oncologists, couldn't have imagined practicing oncology by this strategy. We have another comment or question, I should say, it's both actually, from Ashley. I don't know if it's Ashley Wells or another Ashley, but this is a good one. So we're going to start with Dan this time. COVID has demanded that organizations across all industries pivot their traditional business models. Anecdotally, there are cases in which organizations have realized increased economic efficiencies compared to the status quo way of doing things. In terms of patient care, have you seen as economic efficiencies in the cost of care that may repurpose to funding cancer research? So I think what Ashley's getting at is a kind of a clever way of providing potentially clever way of providing additional funding for cancer research as a consequence of economic efficiencies. So Dan, I'm going to put that one at your feet, and then we'll
Well, thanks a lot, Tucker. No, that's a fascinating question. It's a great question. So the short answer is yes, there have been the efficiencies. Perhaps the easiest example. So I see patients 2 days a week full time. So, and for example, if I had 18 or 20 patients on my schedule pre-COVID, some of those are new patients. Some of those are what we say on-treatment patients who really have to be at the cancer center to literally receive an infusion or to receive radiation. But 8 or 10 of those could be survivors in what we would say is routine follow-up. So I will say that we, and frankly, most cancer centers I'm aware of have made a pretty rapid pivot to adopting telehealth in ways that had not been as rapid before. I mean, this doc is a great example. And so that we're conducting about 15 to 20% of our visits by telehealth, and that money can, so the answer is yes, we are gaining some economic efficiencies that decrease cost. I think the question that's really posed about whether that can be turned back into research funding is a fabulous one, and actually a pretty innovative idea. But I think, it's interesting to see, Brenda, talk about what you say, but would be incumbent upon our individual institutions, or perhaps us as an oncology community, to say that if we're able to do that in this COVID era, we all know how budgets work, is getting that from your operational budget into a research budget. I'll be frank, we have it is a brilliant idea, and the fact that it's been mentioned now is something that I'll certainly be thinking about as the director of a cancer institute as I talk to my higher ups here at St. Luke's.
Okay, thank you, Dan. Brenda, any perspectives you wish to add?
Yeah, so I think it's a fascinating question with regards to, can you pivot that to additional research funding? I think one thing I would add, and I completely echo what Dan has said, is what sort of COVID forced all of us to do is to embrace sort of this telemedicine, telehealth in a much more accelerated way than we have ever thought we could or would have, and it's working really well. The other thing is, I think it has really opened up research opportunities in a way that Dan alluded to, particularly sort of in survivors or people who are in remote areas, can participate in research in a way that they couldn't previously. So some of the things you can actually deliver questionnaires, you can do some data follow-up that we can now set up systems remotely. So the opportunity to actually reach maybe some underserved areas or patients who would normally not be as engaged with St. Luke's Cancer Center or with Masonic Cancer Center, this may actually give us an opportunity to expand some of our research opportunities, and in that sense also may build sort of more engagement with our centers from a donor and engagement perspective. So I think there could be spin-offs on that we have not even begun to think about or realize yet.
Okay, Brenda, thank you so much. I think one thing that everyone, I'm sure, who's listening to this is aware that although economic efficiencies have begun to pop up, most healthcare systems have lost a tremendous amount of revenue in the past several months due to lack of actual procedures and many other things. Hannah Stotts has been pestering me for 30 minutes to ask a question. If the question is, after you're done running the KTM, can I pursue a career in cancer research? The answer is yes, you can. But you may have another question, so please, what's on your mind?
I don't look good in a lab coat, Tucker, so I think
I'm not going to touch that one.
I had a question that I really feel is actually more of an opportunity for the doctors to send a message to those people that are watching. You talked about it a little bit through Ashley's question, but one of the concerns that my friends in the healthcare industry have had recently is that people are really hesitant to go into hospitals. I mean, Brenda, you started out your slide talking about how elective procedures are being paused for now. That makes sense. I think what we're concerned about, or should be concerned about, is those regular checkups that people are supposed to be having at certain stages in their life. Make sure that they're getting a prostate exam, that they're getting a mammogram. Some of those things that we just want to make sure people are doing to be preventative or on the early end of detection of cancer. And I think maybe you can speak to this, but I believe we've seen a pretty big and concerning reduction in the number of people doing that. They're just skipping those appointments and putting them off. And I would love for you to speak, especially Dan, with what you do in colorectal cancers. I mean, that is a huge concern for miss those appointments. And so maybe you can just assure our viewers that, that hospitals have taken precautions, and that there's a lot of opportunities right now in telehealth to address some of these things. But I just wanted you to maybe speak to those things as a cautionary note.
Yeah, Hannah, it's Dan. I think that's a great point, and I think it's a concern that actually emerged fairly early in the COVID pandemic. Is just that as awful as COVID is, and as novel as it has been, and it's frankly upended the world in a way we haven't seen in a century. There are still more people in the United States that die of cancer and heart disease than COVID. I mean, over whatever the awful number is now in the United States of 175,000 cases or something like that. Every year, there's over 600,000 cases of cancer, and yes, we have seen anecdotally. So I've actually heard this more from my cardiology friends. I think just because the real-time consequences of not coming in with a heart attack or acute coronary syndrome can be immediate death or heart failure, and is seen just on a time scale that's much more compressed than we do in cancer. I think as a cancer doctor and researcher, we definitely have that concern that people are putting off routine screenings in a way that don't have the data to show that we're seeing more advanced cancers, but man, that is absolutely a concern in the field of oncology. So I would stress, that to all those listening, is to not put off those routine cancer screenings that are age appropriate. That yes, that our health system, and I think frankly most health systems, have gone above and beyond to ensure the safety of our patients, their families, the physicians, our staff. I was just listening to the radio talking about sports and the bubble, and the NBA bubble and the MLB bubble, and the commentator was saying, oh, the NBA bubble is probably the safest place to be. But I think, quite frankly, honestly, in some ways, the hospital and the clinics are the maybe second safest in the sense of the procedures that we take to keep people safe. So yeah, I appreciate you bringing that up, Hannah, that people still need to be able to do some of the more important wellness maintenance, which does involve cancer screening.
Brenda, would you like to add to that?
No, I actually was just going to say, I think exactly as Dan said, I think it's critically important. And I think that the healthcare institutions, I think, are truly, because of the really tight precautions, are one of the safer places. Everybody's using, personal protective equipment. There's so much attention made to scheduling, to space people out for social distancing, just even from a scheduling point of view. And it is actually much more streamlined. So you literally, at least in our place, you check in, you're put in a room, you're not sitting in big waiting rooms with lots of people. So I do think there's been a ton of attention paid to the safety of patients and staff. And there's a lot of criteria in place to really minimize staff who actually come to work and protect them as well. So I think it is much more imperative to say, what do I have to do to continue the important screenings, the important health maintenance visits, because there are things that are truly preventable. And if we can stay on top of it, we can actually prevent. And I think it's critically important to do so.
Okay, thank you. Well, as I look at the clock, we are just about right on time. I want to thank Dr. Weigel and Zuckerman for their outstanding presentations as usual. For everyone who's still on the call, thank you for your interest and your commitment to this cause. And maybe I'll just throw it to Hannah and give you the final word.
Well, thank you. Thank you, Tucker. Thank you, Brenda. Thank you, Dan. We are so honored to be a part of an organization whose sole purpose is to raise money to support you and what you do and what you're doing for the future of cancer patients all over the world. What the work that you do just has such a huge impact on the future and reaching a cure. And we're just very incredibly grateful for you. And I wanted to now turn this as an opportunity to plug our event that is happening tomorrow night. It is the capstone of the Killebrew-Thompson. We had a month-long remote golf tournament. We've had this wonderful educational forum with you. And tomorrow we will cap everything off with our virtual auction and awards gala. It will be live streamed on our website, on Facebook Live. It's going to be fun. We've got a lot of interesting and entertaining things planned for the show. But every dollar that we will raise tomorrow night, our beneficiaries that you heard from today can take those dollars and they apply them sometimes 5 up to 7-fold at the University of Minnesota is the latest number I've heard, through other federal and matching grants. So this is an opportunity for you to take $100 and we will help by donating it to these beneficiaries, turn it into $700, and it goes directly towards cancer research. So I hope that those that have tuned in and learned how important and vital cancer research is for getting a cure for cancer will tune in and watch our show tomorrow night. I promise it'll be entertaining. It won't last longer than 45 minutes, so it'll be a good start off to your Friday evening. You can visit our website at ktmgolf.com in order to get a link for that. It starts at 7 p.m. Mountain Time, and we'll also be sending an email to all of the participants that joined us today. So thank you so much to all of our doctors for doing this event for us. We really appreciate your knowledge and your participation in our event. Thank you.
Okay, thanks everyone. Have a good weekend.
Thank you.
See you
Thanks, everyone.
Tomorrow night.
Bye.
See you tomorrow.
Okay. Thank you.